Okay, greetings everybody. Thank you so much for being here. My name is Dr. Makena Mbogori. I'm an orthopedic surgeon from Nairobi, Kenya. I completed my medical school and orthopedic surgery residency at the University of Nairobi and currently undertaking a subspecialized fellowship training in upper extremity and sports medicine in Canada. And it's my great pleasure that I welcome you to this Diversity in African Orthopaedics webinar. I'm honored to serve as the moderator for this important and timely event. Welcome to everyone. So this is a collaborative webinar and it aims to shed light on the significance of diversity in African orthopedics, recognizing the diverse perspectives, experiences, and contributions of orthopedic professionals across the continent. I would like to gratefully thank our co-sponsors, that's the Ruth Jackson Orthopedic Society, South African Female Orthopedic Surgeon Society, and the Pan-African Women Association of Surgeons for collaborating with us to present this webinar. Throughout our discussions today, we will explore the impact of diversity in orthopedics, including the influence on patient care, research, innovation, education, and workforce representation. We will delve into the challenges faced, the progresses made, and opportunities that lie ahead in creating a more inclusive and diverse orthopedic community in Africa. We have quite the esteemed panel of speakers today that bring a wealth of experience and perspectives within the African regions and backgrounds, reflecting the rich diversity that exists within African orthopedics. Their collective knowledge and experience will inspire us to embrace and promote diversity in all its forms, fostering an environment where everyone's voice is heard and respected. They will tell us more about themselves, but I will briefly introduce each one of them. We have Dr. Lebo Pule, who's a final year orthopedic surgery resident at the University of Pretoria, South Africa, and she is on the executive committee member of the South African Female Orthopedic Surgeon Society, and she'll be telling us all about that shortly. We have Dr. Linda Suleiman, a hip and knee arthroplasty surgeon and Associate Dean of Diversity and Inclusion at the Northwestern University in Chicago, United States, and currently serves as a vice chair of the Women in Arthroplasty Committee for the American Association of Hip and Knee Surgeons, and is a first woman of color to enter the presidential line for the Ruth Jackson Orthopedic Society, and I'm quite excited to hear all about that as well. Miriam is a consultant breast surgical oncologist, so not only orthopedic surgeons here today, but she's an assistant professor in the Department of Surgery at the Aga Khan University Hospital in Nairobi, Kenya, and the co-founder of the Pan-African Women's Association of Surgeons, which was developed to mentor and provide transformative leadership for women in surgery in order to improve surgical care on the continent, and is also part of the Kenya Association of Women Surgeons. Part of our panelists, we have Dr. Temi Olufemi. She is an orthopedic surgeon from Nigeria and a fellowship trained in trauma and arthroplasty, widely recognized as a passionate advocate for improved education and patient-centered care in Nigeria and beyond. We have Dr. Andrew Kaggwa, an orthopedic surgeon from Uganda, currently working in Kenya with passion for research, particularly focusing on issues around the public health aspect of orthopedic surgery and health inequities. And finally, Dr. Alpha Seifu, a professor of orthopedics and trauma surgery at Tikur Anbessa Specialized Teaching Hospital, Addis Ababa University in Ethiopia, and the founder and executive director of the Mekiltesh Initiative, a local nonprofit mentorship program for Ethiopian women in medicine committed to empowering the next generation of female surgeons in Ethiopia by fostering mentorship and education. I mean, this group of people today is quite impressive, and I encourage all the participants to actively engage in the discussion. Kindly put your questions in the chat box in the Q&A, and let's seize this opportunity to learn from one another, broaden our perspectives, and collectively work towards a more inclusive and diverse orthopedic community in Africa. So I will begin the section today by just talking about why orthopedics, why diversity, why does it matter, and why specifically for us as orthopedic in the orthopedic surgery space, right? So for me, it's not just an ideological argument, and I think for everyone too, it's not just this new thing that everyone is talking about, that this nice thing that we should, have in committees and discuss in the department. It's actually an evidence-based strategy that can immensely enhance the work environment and improve patient care. So when we talk about diversity, it has many definitions, and we've, a lot of it has been described, but for me, it's just encompasses just amazing and beautiful traits that make us who we are, and encompasses recognizing and accepting everyone's uniqueness and individuality. We have another term known as intersectionality, whereby individuals may have two or more characteristics that, if we look at this wheel of power and privilege, that different characteristics have been put together from the center going outwards, and in the center, people perceived to have these traits seem to be the ones in power, and everyone else on the outside seems to be marginalized. And this is just the reality of how things are. If we're not willing and comfortable to talk about this reality, then we'll never be able to come up with a solution. But if you have two or more of these characteristics, it just compounds the disadvantage. And McKinsey, which is a top audit firm, in 2015 published the Delivering Through Diversity report that actually showed that organizations with more than 30% of diversity performed better, attracted top talent, were more innovative, and made better decisions. So as we said, it's evidence-based strategy. So why does it matter specifically in orthopedic surgery? I mean, if we do not talk about this, if we do not think about diversity, we will lack lived experiences to speak on social issues that affect our diverse patient population. We treat all kinds of patients, all age groups, all religions, all cultural backgrounds. And if we are not able to understand from a personal point of view what they're going through, we may miss some of the clinical aspects of it. We're missing out on some of the best and brightest students if we do not consider diversity. Also lose and risk being irrelevant. And I think most importantly is the lack of diversity in the health force is basically directly correlated to health inequities. And we have several peer-reviewed studies that have shown this, that in orthopedic surgery specifically, there are racial and ethnic disparities that cloud our clinical judgment when it came to, for example, lower limb amputations, prescribing knee arthroplasty surgery, and communicating with our patients, which of course will eventually lead to some clinical disadvantages. And why does this come about? It all has to do with implicit and unconscious biases, which are feelings and attitudes that we have that we may or may not even be aware of as individuals to certain groups. And these are some of the things that are ingrained into us from when we are born in the environment that we live in. And understanding that we all have biases, first of all, is the first step to mitigating and reducing the effect. No one is exempt from this, okay? And these are some of the biases that we go through that each and every one of us needs to be aware of, because it all begins with us, okay? Why should we care about this implicit bias? Because unconsciously, it shapes our cognition and attitude, impacts decision-making, particularly affecting patients' overall experience, our clinical judgments, and most importantly, our work environment. The students that medical students and residents that we interact with every day, how are we encouraging them or discouraging them from joining the field of orthopedic surgery? And some of these barriers are evident with a lack of visible role models, and not only gender. Gender seems to be, of course, one of the main disparity that we have in orthopedic surgery, but it's not only that. We have in Africa many religions, we come from different cultural backgrounds, religious backgrounds, abilities and disabilities. We need to be able to have role models within each of those groups for the ones coming up to see. Also, flexibility and unconscious bias needs to be reported. And mentorship and sponsorship needs to be a part and parcel of our practice. So I'm just going to try and move quickly because of time, but this is one of the IODA publications in 2019 that actually inspired me to be part of IODA, because according to this publication, it's only Tanzania that submitted statistics on their female orthopedic surgeon proportion. And I can bet you in 2019, I was in orthopedic surgery. So, I mean, at least for one person needed to be else in this group from Kenya. And I'm sure there's so many other countries that are not represented here. And that's part of the reason, one of the things that I would like us to achieve as IODA Africa is to be able to publish research that actually shows that the numbers are representative. We are there, the role models are there. In Kenya, in South Africa, in for the medical students, for residents, there are mentors and allies available to expose people to orthopedic surgery early. Flexibility in training is a reality. It's not just only about completing, being on call and being always there. It should be competency based, and we should be able to accommodate childbearing, breastfeeding, and have flexibility in trainee positions as well. Some of the other things that we can do to mitigate unconscious bias is making it reviewing the selection process for residency programs, for job positions, making the promotion transparent, having visible and committed leaders like the ones we have here that we can see, and also having discussions like this that shed a light on the importance of diversity. So we have already a few mentorship programs running, like the PAWAS, which Miriam will talk about, in South African Female Orthopedic Surgeon Society. And it's important for us to continue having this discussion, and that's what IODA is all about, and it was formed to basically drive diversity, and it's a hub for discussion. If you go to our website, there's lots of resources on there, and I'll just skim through and welcome you to join IODA if you haven't already. I'll put the code there, and specifically for those in Africa, Orthopedic Diversity Africa email address is there. Kindly email us if you'd like to be part of the team. We are looking for volunteers to join committees. One of the things I've mentioned that we would like to do is research, diversity related and otherwise, and sorry about that. We definitely need you to be there. So I'm going to end now and invite Dr. Sinda to give her presentation on Ruth Jackson Orthopaedic Society.
Awesome. Can everyone see my screen? Wonderful. I just want to thank Makena and IODA for inviting me to speak here today. It's really quite an honor to represent the Ruth Jackson Orthopaedic Surgery Society. We are the largest US female orthopedic surgery society, and we've been here since about 1983. I'm an orthopedic surgeon. I specialize in total hip and knee arthroplasty. I will tell a little bit about myself, but in my academic role at Northwestern University, I also serve as the Associate Dean for Diversity and Inclusion, really looking at how we look at DE&I from the lens of health equity, retention, and recruitment. So a little bit about myself. I was actually born in the US. I was born in Washington, DC. We lived here for the first 3 years of life when my parents then moved back to their homeland of Somalia. We had no intentions of ever leaving Somalia, but unfortunately, with the impending civil war, we left Somalia in the early 90s and actually immigrated to Canada, which is where I spent most of my life. I completed my middle school, high school in Canada, and I ended up receiving a scholarship and moving down to the US to the University of Maryland. I ended up completing my medical school training at Howard University, which is the largest and oldest historically Black college and university in the United States. I then moved over to Chicago to complete my orthopedic surgery residency at Northwestern. And at that time, I was the first Black woman to train in Chicago at Northwestern University. And then I ended up staying in Chicago at Rush University, one of the leading institutions for hip and knee replacements and reconstruction, and now went back and returned on faculty. And I'm heading into my 6th year of practice here. So it's really an honor to be back amongst colleagues. I wish this was in person and can be back in the continent, but hopefully one day we'd all be able to meet up soon. So what do we learn from lessons from diversity in US orthopedic surgery? You know, US orthopedic surgery it's probably has been behind the mark. And I would say the wake-up call for us in the US was in 2020, when it was this renewed social justice and sort of health equity movement due to unforeseen circumstances of what we were seeing, of how the poor treatment of Black and Brown individuals in the US. And, you know, at that moment in time, it was really a wake-up call for orthopedic surgery, being 96% white men. And, you know, we've been at 6% women for a very long time. We just hit 10% this year in practicing orthopedic surgeons, but we really remain at about 1.2% of Black surgeons. So when we think about diversity and inclusion and what underrepresented in medicine really means, it's really based off what we call the AMC. The AMC is an overarching body of medical colleges in the United States. And sort of this definition was really adopted to look at the US population. So these 4 groups is what we define as underrepresented in the US because it's based off the US population. And what we've looked at is at the Institute of Medicine, when we looked at racial and ethnic minorities, they tended to receive lower quality of healthcare than non-minorities, right? And this is despite controlling for some of the barriers we see in the US, which is insurance status, income, health literacy. And so the solution to the Institute of Medicine, this is back in 2003 when they made this statement, was really to substantially improve the quality of care for minority patients. We really had to increase the proportion of underrepresented physicians and surgeons in the US. So why we need to do this is to better care for diverse populations. We're changing as a healthcare system in the US. We're going from a volume-based system to a value-based system. So it's not just about me doing 300-400 total knee or hip replacements. It's about the outcomes of those patients, right? How many people are being readmitted? What is the infection risk? What is the fracture risk? DVTs, pulmonary embolisms. So it's really understanding what the whole patient is doing, not just about how many surgeries I'm doing. And when we look at orthopedic diversity and disparities in healthcare, we have very stark disparities across all of our subspecialties, from spine surgery, hip and knee, shoulder, where we see patients are treated differently. We see patients with poor outcomes based off their race, ethnicity, and gender. So the current state of orthopedics in the United States still remains at 6%. Again, we just hit our 10% mark. We have more women training in our residency programs right now at about 15%. But again, as you can see, 1.6% of Black surgeons, and that number really has not changed in the US, despite the population of the US being about 15%. So my group published on this. These are the 4 women I trained with in residency, where we looked at orthopedic women and across all of our subspecialties. And what we find is that change in that delta really has been stagnant compared to other surgical specialties like neurosurgery and thoracic surgery, who had much more increases in growth. Now, when we look at not just matching into orthopedics, what's the actual growth and trajectory in leadership of women in orthopedic surgery? You could see when we look at an academic standpoint, the majority of orthopedic surgeons who are women are still at the lower instructor and assistant professor level, and very, very few chairs of departments of orthopedic surgery. And we look at overall the memberships data across all of our subspecialties, this is sort of a pre-marker, and you can see, my subspecialty of hip and knee being almost the lowest percentage compared to pediatric orthopedic surgery, which is the majority of female surgeons entering that subspecialty. So the Ruth Jackson Orthopedic Surgery Society, we've been around since 1983, but it took, 40 years for a woman of color to become presidential line. So even looking within diversity, what we really haven't started talking about is intersectionality piece, that with gender, race, ethnicity, sexual orientation, which these are things that we have not looked at historically. But what RJOS's primary fundamental charge is to really look at promoting the professional development of women in orthopedic surgery from the time you're a medical student all the way up to the time that you become a practicing surgeon. And I think it really is about these 6 domains, which is what we focus on, is diversity and inclusion, meaning not just the gender aspect, but the intersectionality piece, looking at professional development, really establishing a leadership curriculum, enhancing resource sharing. You may be the only one in your group, your practice, your institution, and it's really about that knowledge exchange and really building community strength. Then we started thinking about membership and really engaging our membership, creating sort of a benefits package for our members, access to materials, access to mentorship, and sort of that networking. And the last part is really research, which I know Makena has highlighted extensively, is how do we empower our members to participate in lead research? And I'll show a little bit about how we've tangibly changed that. Our membership currently stands at about 1,100 surgeons, women in orthopedics. You can be a male member and join the Ruth Jackson Orthopedic Surgery Society. It's not limited to just women. And then when we look at the research piece, how can we make it easier, more accessible for women in orthopedic surgery to really take part in research activities, to again, build that portfolio and leadership from becoming an assistant professor and instructor to the professor level. And we've done this through research grants. We've had a long-term partnership with Zimmer Biomed looking at clinical and basic science research. You present this research at an annual meeting at the AOS, and we started a traveling visiting professorship as well. Now, I want to also put in a plug for my own subspecialty training for those who are in hip and knee arthroplasty. I founded this group within our American Association of Hip and Knee Surgeons, really looking at how women can really rise in arthroplasty. We are less than a percentage of women who are performing hip and knee replacements, despite the majority of patients being women who are presenting with hip and knee complaints. I just want to shamelessly plug, we do have a traveling fellowship where it's a 2-week fellowship. We invite you to apply through our website. This will take place in October, where you can come to 3 of our US sites and really learn more about hip and knee replacements. And then I go back to, again, that intersectionality piece. To date, we have 7 Black women who are fellowship trained in hip and knee replacements in the US, right? A large population. We talk about over 1 million hip and knee replacements being done a year, yet only 7 Black women representative. So the challenges we've sort of faced in orthopedic surgery, one is that sense of belonging, right? It's 96% white men. It's a sense that, you can't be what you can't see, right? Being able to work with women and visible minorities to be able to share in those similar experiences. It's a very competitive specialty here in the US. We've sort of mitigated some of this with removing, step 1 as a scoring system to just a pass-fail. So more of a holistic approach of really evaluating applicants into orthopedic surgery. One of the biggest barriers we have is that orthopedic surgery is not one of the core curriculums for a rotation. So not everybody is going to experience orthopedic surgery. You sort of have to seek it out. And it's hard to seek something out that you can't see yourself being in. And really, it's the sponsorship and true mentorship, right? It's really building the foundation of being able to participate in academic arthroplasty, academic orthopedic surgery, and being able to have people speak on your behalf when you're not in the room. And that's what true sponsorship is really. So, the motto I have is the future is female. Today is our day. We have to push forward and really help each other out and in uplifting our community, because what it comes down to is our patients need us. So I want to thank IODA and Makena for having me here today, and I look forward to the discussion.
Thank you so much, Linda, for that wonderful presentation. We'll go straight to Dr. Lebo Pule from South Africa, telling us about South African Female Surgeons Orthopedic Society. Thank you.
I'm not sure if you can hear me.
We can hear you very well, and your slides are visible, so you can go ahead.
Okay. Hello and a good day to everyone who's just joined on the webinar. It's such an honor to be given this opportunity to be speaking on behalf of the South African Female Orthopaedic Association, and especially being invited among such a strong panelists and other speakers that are such trailblazers in orthopedics and in diversity. It is truly a privilege for us. I'm going to give you a bit of a report on what we've been doing from the South African point of view in order to promote and foster empowerment of women in orthopedic surgery. So I'm representing the South African Orthopaedics Surgeon Society. We are a fairly new organization that was started about 3 years ago. We have 4 executive committee members, 3 of which are qualified specialists. They're pediatric orthopedic surgeons. And currently on our stats, we've got 83 members that have joined the association. Just to give a bit of a background about myself, I'm currently doing my residency in the University of Pretoria. It's our capital city in South Africa. I'm one of the executive committee members of SAFOSS. And I was also one of the first Black female class representatives ever in my institution. in the orthopedic department. And while I was there during my reign, I made sure that we made a few changes to how we did things in our department in orthopedics. And one such achievement was writing up our first pregnancy protocol, which was now published this year. So our objectives as the South African Female Orthopedic Surgeon Society is mostly in the same keeping as with those of IODA and other organizations around the world, and is to push on professional development and career progression for women, and to also promote orthopedics as an option, as a speciality for the minority groups. We also are quite involved in the writing up of policies, especially policies that are based on gender-specific issues, but now extending to actually issues that affect more of the minority groups. We are also very much involved with research in our society, and overall we want to promote organizational excellence within our members. So just a bit of our background: our first medical schools were opened in the 1920s. Our first female orthopedic surgeon was in 1984. The numbers are steadily increasing up to this year. We currently have 70 female orthopedic surgeons that are registered now with our council. And although the numbers seem to have come down in terms of our training over the past years, like I said, it's still on an upward trend. So we are much improved from what it was before. So with having more females in orthopedics, or a better representation of the members in orthopedics, we're starting to open more and more doors for opportunities for the minority groups, and we're starting those discussions in various institutions in order to help in starting up of how we can diversify our training. And therefore, like the other speakers have mentioned, if you've got a more diverse people in orthopedics, then you can offer a better service to the different communities that you have in your country. So we've been busy with a couple of things over the 3 years since we've been established. We've been running a series of webinars. These webinars are basically on general topics, not per se about orthopedics, but about personal growth and how we can assist the females and other minority groups to navigate inside the world of orthopedics, or a world where it is male dominated, where they feel marginalized. So we often have speakers who are non-orthopedic surgeons. We have psychologists. We basically have speakers from any profession who are pioneers in their field, and they give webinars. And most of these topics that we provide are suggested by our members, because it's issues that affect them on a daily basis. We also run dry bone workshops. These are centered around our undergraduate colleagues, the students, as well as our house doctors, the interns. So it gives them an introductory workshop in orthopedics to help them to decide whether they want to participate in taking orthopedics as a speciality. And it offers them the opportunity to reach us and to ask us any burning questions that they might have with the speciality, being it on a professional level or being a personal level. We also have a mentorship program within our society, where every member in our society is allocated a mentor according to their different levels of studies. And we do regular reviews on how this is going for the members. And so far, we've obtained positive feedback from the members about the mentorship program. This was also implemented in our South African Orthopaedic Association. Actually, last year, they also started the mentorship program, where all the registrars or fellows can receive a mentor and be assisted. We've been involved, like I mentioned before, with the writing up of protocols to change the systems in our institutions. We wrote a pregnancy protocol that was proposed in 2021, finally got accepted after much discussion with the university and so on, and the hospital management. And it was accepted actually this year, and that's what we're practicing now. We've also been involved with extensive research. I chairperson, the SAFOSS chairperson, Dr. Tiart, as well as I was in collaboration with Dr. O'Connor. They looked at the experiences that women in orthopedics that are training in South Africa are facing. And it basically showed that it's similar to what the rest of the world is experiencing in terms of marginalization and family planning and racism and sexism. We also have been involved with trying to offer more courses for our resident female registrars. We have a collaboration with Zimmer Biomet, which is currently busy with an initiative to promote females in arthroplasty. So I was quite happy to see Dr. Suleiman's presentation now. So we also have seen the problem with arthroplasty, and we're trying to push more women to join arthroplasty. Our numbers in arthroplasty are still not as much as theirs. So Zimmer Biomet has been sponsoring educational trips where we take the residents to different institutions within the country, and they can learn about arthroplasty and introduce it to them. They say what you do on the left, you must also do on the right. So as much as we've been doing a lot of work in trying to push diversity, we also encourage a lot of relaxation and social events and a balanced life. We encourage our members in the different regions and provinces in South Africa to have regular regional socials where they can basically relax and share ideas, and to also help to strengthen that bond amongst our members. And that's the only way that we'll go forward. So what's next for us? What's in the pipeline? We want to offer more fellowship opportunities. Not only, like I said, we started the arthroplasty one, but we are hoping to do another one with spine and so on. Hopefully with more sponsorships, we might be able to do that. We'd like to participate in a lot more published research from females in our membership group, and to also have a more diverse representation in our leadership roles, especially in the South African Orthopaedics Association, which we've recently joined, as well as some of our registrars have also joined the South African Registrars Association as well. So we'd like more female representation in that. And we also want to have more diverse representation of our invited speakers at congresses, etc. But I think the point and the idea is we share the same vision as IODA and the other organizations. We want to basically attract people into more diverse population into the orthopedic speciality. This can only help to improve on the healthcare that we provide for our patients. Thank you.
Thank you so much for that. Wow, SAFOSS is doing amazing, amazing things. We're certainly going to pick a lot of lessons from you and continue to collaborate with Zimmer. I'd like to just highlight that Zimmer has actually collaborated with IODA, and we've shared a couple of the EMA residents in a forum, which we got a lot of applications from Africa, and we're going to let them know shortly we've been able to do that. So in collaborating with industry is very important, and it's good to see that that is already happening. So thank you so much for that presentation. Now I'll invite our only non-orthopedic surgeon here. Miriam is a good friend of mine from Nairobi. She is a general surgeon, but very much welcome here today, even though as orthopedic surgeons, we left the soft tissues to her. She'll let us know all about PAWAS, Pan-African Association of Women Surgeons, and all that they do in mentorship, not only for general surgeons or orthopedic surgeons, but for all surgery specialties in Africa. So thank you so much, Miriam. Welcome.
Thank you so much. Can you hear me okay?
Yes, we can. And your slides are visible. Thank you.
Sure. I'm going to try to So thank you, Makena, for the opportunity. I think as a breast surgical oncologist, the closest we get, we're still at least hovering around the general location of bones, but that's really in the context of near the ribs and everything else, but really trying to talk to
Sorry, Miriam, I think you switched off your microphone by mistake.
Sorry, can you hear me now?
Yes, we can hear you now.
Yeah, sorry about that. I was just saying we're close to bony structures, but I was just sort of going back a little bit and saying this is frequently sort of thinking about surgery in Africa. One sort of has both extremes. This is one of the relatives of a patient who got, successfully treated, had an acute appendicitis, was successfully managed and discharged. But the reality is, for quite a number of surgical patients, at least in Africa, there's little to smile about. And so looking at, over the next few minutes, just sort of giving, because this is a fairly international audience and really honored to be part of this, just talking about the scope of the problem, looking at our current scenario, and then sort of honing down to why we need more women in surgery in Africa, and then looking at retention strategies. I know I'm preaching to the choir because we know, for instance, that 9 out of 10 people have no access to safe surgery. And this is more so in sub-Saharan Africa. And if we look at the data from 2015, where they did a survey of over about 5,000 registered surgeons, we found that less than 1% of women had female representation in general surgery. So pretty much speaking to similar scenarios across different continents. And so thinking about what is the role for having more women? As I said, I'm preaching to the choir. We do know that surgery is a high ticket item, frequently looking at the burden, at least in sub-Saharan Africa or globally, we are saying there's about 143 million additional procedures needed, but also thinking through the fact that surgeries, at least in many low and middle income countries, is associated with financial toxicity and catastrophic health expenditure. Sort of leaning towards my work as a surgical oncologist, perhaps we might not intuitively realize is that more than 80% of all cancer patients are going to require a surgical procedure, and surgery sort of covers the continuum of care, whether it's in diagnosis, or whether it's preventative, like, excising a polyp, whether it's definitive or curative, where you're resecting either a tumor, whether it's reconstructive, for instance, when you're doing limb sparing or limb salvage surgery, and you need to definitely reconstruct. So it really covers the entire spectrum of care. But again, if looking at beyond the burden of general surgery, even looking further at oncology surgery, we are recognizing that, one, we are in the middle of a syndemic in Africa, where we're not only seeing the increase in infectious diseases like COVID, and we're also seeing an increase in non-communicable diseases, including cancers, which have doubled actually in the last 30 years, really underscoring a need for an expanding workforce. Again, this is has been previously mentioned, is really trying to look at how do we provide surgical services through the window of value-based care. We do know that cancer diagnosis and treatments are expensive, and that also translates to surgical care. But then how do you deliver care at a cost that's not necessarily going to break the bank, but how do you ensure the quality of care provided, and what are the ethics of practice that govern that? We do know that in sub-Saharan Africa, we do certainly have the highest health worker deficits. And if we look at the physician to total inhabitant ratios, are quite high. For instance, if we look at surgical oncology, we see that there are less than 2 surgical oncologists per 100,000 of the population in Africa, as compared, say, for instance, to about 35 per 100,000 in the UK. So really being in the scope of why we need to why we need to expand the workforce. And if we look at cancer as a paradigm, we see that not only are our patients diagnosed with advanced disease, they frequently do not complete their care. And if we look at a deeper dive into the reasons behind this, we see a constellation of factors, cost being that high ticket item they're having to pay out of pocket, compounded by the fact that health system barriers, where we know that patients will see 4 to 6 healthcare providers before a definitive diagnosis of their cancer is made, and then further compounded by social cultural barriers that exist. Now, we believe that women are uniquely placed to expand, to fill in this gap, especially as far as cancer surgeries and the workforce is concerned, because just because of the social barriers, you have a grandmother coming in and she's reluctant to perhaps disclose that she's having vaginal bleeding because, that's taboo to disclose that information to somebody who's the age of her grandson. Or sometimes for cultural reasons, nobody wants to have a clinical breast exam by somebody on the opposite gender. So we're saying there's really a role for us to not just expand the workforce, but really trying to think about what are the elements of respectful care and culturally sensitive approaches that can actually help us to deliver better care for our patients. Sort of looking at the pipeline in sub-Saharan Africa, we do know that if we look at the demographics from med school, we're starting to see a shift more, almost like 60% female representation and 40% male. But then if you look at the surgical fields, just across all specialties, this sort of dwindles down to less than 1% in many centers. And it's really looking at, it's not a lack of interest, because ladies we've discovered will frequently enroll in surgical specialties, but will often drop out within the first or second year due to a number of challenges. So it's really about how do we strengthen the entire pipeline. So the Pan-African Women's Association of Surgeons is really just trying to build a community of practice and looking at how do we get to inspire, encourage, and insist women to enroll, but also to get retained within the surgical workforce. And so we've tried to do this through trying to increase the visibility and impact of women in surgery on the continent. And it's really looking at not just increasing women for women's sake, it's how do we give each of these women the skills to become transformative leaders in their health ecosystem. Now, it could be as simple as in the clinic where you're working, in a position of authority, maybe in academia or in the head of a hospital, but how do we give them the skills that ensure that we are able to actually create a positive impact? We do know that as surgeons in sub-Saharan Africa, we do have many roles. You're frequently the team leader. You're trying to enhance build your communities of practice, but there's a real role around surgical advocacy to push the needle in terms of, even from a policy level, trying to increase investment in surgical workforce. We always say surgery is a neglected stepchild of global health, but it's really about how do we create the arguments that investing in surgical services and improvement of care is actually going to impact the health systems positively. And so it's really about empowering women to become change agents, and then by extension, improving women's health and surgical care, not just for women, but for the entire populations, and also thinking about how can we act locally to impact our communities. And so to this end, we've had a couple of education, since our humble beginnings in 2015, we've had a now consistent forum where we have constant education to both members and members of the public across all specialities. Makena, we're looking forward to an orthopedic awareness for members across Africa, and really consultation. Excellent. Excellent. And also trying to look at support and mentorship, recognizing that the support for academics is probably likely to come from their host institutions. One of the gaps that we recognized was really around research. So we've been partnering with research organizations like AuthorAid to have paired research mentorships, where we pair different clinicians at different stages from both Africa and the diaspora to work on certain projects over a 6-month period of time with deliverable outcomes, like maybe having a protocol or having a manuscript or a design, and sort of having clear deliverable outcomes. We've also been trying to increase our footprint in terms of trying to improve surgical care. And so through our partnerships, we've had several surgical preceptorships, breast surgery, colorectal surgery, really working through the national surgical societies. This is just a snapshot of our work in Namibia, and one of our members in South Africa doing a breast surgical preceptorship, and also to, again, send out this is my plug-in for, we have big dreams that have been on hold around creating more awareness around safe surgery. So we are hoping to get more collaborators on this call who can join us. We're looking at 2024 in ascending Kilimanjaro, really just to raise awareness around the need for safe surgery, especially on our continent. So the downstream effects of this over the last couple of years, we've had 5 surveys. We have 1 prospective study that's ongoing and 2 publications. We've had an increase, our members have had an increase to resources, whether it's from different research organizations or surgical care societies. And again, we've generally seen an increase in the interest in national surgery associations for women, which is great. When we started, I think we were the only, we're probably one of the 2 organizations, but we're now starting to see a lot more women in surgery organizing national associations of women in surgery. So I think our next step is really looking at how can we collaborate effectively to amplify not just our voice, but the voice of all women in surgery globally. And we're trying to look at increasing our community outreach activities so that we actually see, the downstream impact of that, and developing critical partnerships with all players, and really trying to leverage each other's strengths. And so in summary, I would say we do need to think about delivery of care through the lens of universal healthcare coverage. As we said, poor people cannot afford poor care. So it's really about how do we bring the quality, the value base to that? How do we introduce, a generalization of surgical skills and services across the continent? I think there's, as we know, an urgent need for expansion of surgical workforce and an increased diversity, and engagement and enrollment and retention of women is going to be key. So I just want to thank you. I just want to thank IODA and Dr. Makena for this opportunity to share a little about what we're doing, and to really sort of champion the call that's come out today to let's try and see how we can work together to amplify each other's voices. Thank you.
Thank you so much, Miriam, for that wonderful presentation. PAWAS has been doing quite a lot. I know I interacted with you first as a resident, and we are certainly going to continue to collaborate, IODA and PAWAS. So I'm going to kick off the discussion with our panelists, and I'll start with Dr. Alpha Seifu, where and it has come up in a couple of the presentation that the latest worldwide data actually shows that the proportion of female medical students is probably slightly more than male medical students, but this does not somehow reflect in orthopedic surgery residency programs. And maybe I'd like you to speak towards how to mitigate this, and maybe tell us a little bit about your initiative, Mekletif, and how you've been able to do this in Ethiopia.
Thank you so much, Dr. Makena. It's been great listening to all the speakers, and a lot of what you guys said, of course, echoes with what we have here in Ethiopia. And to rephrase your question, it's been true all over the world now that we're seeing a rise in number of female medical students, and it's also true for us here in Ethiopia, and I'm sure it's true in most African countries. Even the year I graduated, the year I entered medical school, we were 50-50, and it was news. And since then, we've had even more medical students than every year. But the problem is it doesn't translate to surgical residency programs. And it's especially true for orthopedics, and it's also true for most other surgical specialties in our country. And when female surgeons make it to the residency program, they're seldom completed. And if they finish it, if they complete it, as someone who has completed a surgical residency, I can tell you that it is not a pleasant experience, to be very blunt about it, for so many reasons. Even if you're passionate about what you do and you like your work, but there's just so many challenges and nuances that you face that even well-meaning male instructors would never be able to see what you're going through or guide you through it, even if they're well-intentioned. And there are a lot of them who are not. So the Mekletif initiative is as a local mentorship program that I co-founded with another pediatric surgeon. a female pediatric surgeon, and I started it immediately after completing my residency because of what residency was like for me, and I wanted it to make it's a little bit better for the next generation of trainees. So that's how it started. So to answer your question, I believe that mentorship is the way to go about it, because it's not for lack of interest in the surgical fields. I mean, when Dr. Linda Suleiman said orthopedics is not a curriculum, that's true for us too. In our training program, it's not a specialty or you get the privilege of being exposed to, but there is interest there. There are surgical trainees enrolling in surgical programs and then dropping out. This is true across the board. So the Mentorship initiative is it's only 8 months young now, so we're still like trying to get it off the ground. But we're making a lot of progress, and we've done a need assessment for over 80 medical students. So the interest is there. But we're trying to deliver what they need and then see what we can do for them and open up opportunities and use our networks to help them advance in whatever they need. Maybe it's starting from work-life balance, personal experiences, childbearing, balancing motherhood with work, everything, including opportunities for research and collaboration, because I don't know what it's like in other countries, but for us, it's a very subjective training program, medical training. So when you find yourself affiliated with, let's say, a prestigious researcher or a consultant that you want to work with, you're at the same time exposing yourself, to be very blunt, to potential harassment. So how do we make it safe? How do we keep them safe and at the same time provide them with the opportunities? So that's what we're currently working on. So I believe mentorship is the way to go about it, because it's not for lack of interest that we don't have enough female surgeons, and specifically orthopedic surgeons. However, there is a silver lining. We're seeing a rise in female orthopedic trainees year by year. We're seeing a bit more. I was the only one in my year. Now, like my juniors, there are 2 of them out of 15. So we'll see. I mean, the future is bright. That's it for me.
Thank you so much, Alpha. Yes, the future is certainly bright. And I think I saw somewhere that if we continue at the rate that we're going, I think there's a study that came up the US, is that it'll take, I think, 400 and something years for us to actually reach gender equity. So we certainly the rate has to increase and keep going further. And thank you so much. We are certainly looking forward to more collaborations between IODA, PAWAS, and Melkitish. So just to piggyback off the issue of training and residency, I'll ask Temi to let us know, we have several training programs in Africa. We have, university-based, college-based, and with your experience as an examiner with the West African College of Surgeons, what are some of the charters or policies in effect within training programs to sort of, help with diversity and make the, process easier?
Thank you, Makena. Thanks a lot for the invite. Grateful to IODA for the invite as well. I'm delighted to be here. I work at the National Orthopaedic Hospital in Lagos, and I also lead the Secret Women in Orthopedics blog. Other affiliations would include working with the AO Foundation, AO Trauma, AO Recon as a member of faculty, and I currently lead a team of like-minded surgeons to advance trauma care in Nigeria by easing access to education and surgically based initiatives. So for residency in West African region, we have 2 phases generally. You have the membership examinations and the fellowship examinations. So residents are encouraged to start the program. They go through the rotations and do the first step of exams to become members of the West African College of Surgeons. Now, at the membership level, you can actually break off and then have some level of knowledge where you like mid-level knowledge, where you're able to perform basic surgeries and work in public district hospitals. But we encourage people to go all the way on to the fellowship examinations. Okay, and with that, in order to encourage more diversity and inclusion, there are several awards that are in the pipeline, some in the pipeline, some already in existence, that encourage residents to be able to take on these initiatives and project all of the things that they have learned to improve care where they're at. So currently, we're starting from the year 2024, there is an award for the best female at the best female in orthopedics at the West African College of Surgeons final closing ceremony. And this will be open to all females who write the exams. The best overall gets the award. Also, in a collaboration with there's a collaboration with Airlines where we're hoping to provide some sort of sponsorship bursaries to females in orthopedics to ease the period of training. All in all, it's training is such that both females and males are able to thrive irrespective of gender in training, to the end that we're able to produce highly qualified specialists who can help increase care and improve care in our sub-region.
Thank you so much for that. And I think one of the important aspects that we've all touched on is our research. And I'm going to ask Andrew. He is quite passionate about research. One of the only orthopedic surgeons who I know who is looking forward to doing a PhD. And I'd just like him to give us some insights about what are some of the existing research opportunities or research avenues that we can utilize to not only clinical data, but also diversity data. I mean, I think most of us, if not all of us, have to do some type of research to finish your training or a thesis or something. And a lot of that can be diversity related. But so what are some of the avenues you feel like we can utilize to churn out research by Africans for Africans about us? Because a lot of the data we use now doesn't really apply in our healthcare systems, because as we know, our healthcare systems are very different than out in the West and everything. So I think you're still, yeah.
Thank you very much. Thank you very much, Dr. Makena. It's a privilege to be here. And first of all, I want to applaud IODA for creating the African division, so that we can tell our African stories. Dr. Kaggwa recently graduated from Moi University. I'm still young in the profession, making 1 year in the profession. So how can we make research? How can we tell African stories? I think that's the question you asked. Yes, so there are quite a number of opportunities out there. First of all, I think all of us as residents do research and present our thesis to the university. But when I looked at one study recently, it showed that we don't implement what we do in universities, and we tend to rely on other Western or European studies. So first of all, we need to trust what we publish and implement it. I work at a teaching hospital, and what we try to do is try to make some small surveys and see what is applicable. What is applicable to us, and so that we implement that. You'll see that what's working in Britain or US isn't easily applicable to us. The other opportunities out there. I happen to be an academic committee member in SUCOT and so many other international organizations like the OTA. There always opportunities for grants, especially for young researchers. Like me, who have just passed out, who have passion to do research. So many international orthopedic organizations have these small grants. All one needs is to have I think a principal investigator, is a senior, I would say, in that matter. So I think that would be the way forward, as telling African stories, and I think now IODA is taking the right path, giving us that opportunity.
Thank you so much. You're very, very true. I can tell you that my thesis for medical school or residency was the bane of my existence, and I spent so much time on it. And whether I implement it, honestly, I'm going to take that as a personal initiative myself to implement all the work that I did. And I think that's a very good place to start. And also within university, diversity research should be as equivalent as clinical research and can't qualify as a thesis. And that's something the university program should be able to accommodate. We're literally running out of time, but I just have one more question to ask. And I'll ask the same question to a couple of our panelists. I'll start with Linda, and then Pule, and maybe Arthur can just mention. So, I mean, we have something known as what it used to be called work-life balance, but now I think we talk about it as work-life integration. I mean, we have the clinical duties that we have, and that is both in surgery and in office, which you have to speak to patients. Then we have leadership responsibilities that we end up being the same people taking up many roles. You'll end up finding that when you volunteer to be a leader in one aspect, then you end up being approached for many things. So it's also how to say no for some of the things and prioritizing that. And then other aspects of life, family, relationships, friendships, traveling, social life. I mean, I call those the soft skills. The software is literally just as important as the hardware, if not more important. And if we don't focus on those aspects of our life, then fixing the hip in the OR and all that stuff, reducing the joints really sometimes will not be as effective if we're not careful. So I'll ask Linda to start, and then Dr. Pule will also give us a perspective, and Dr. Alpha, and then we'll end that so that we don't take too much time.
Yeah, I think the mistake we all make when you start your profession is you want to say yes to everything, right? You want to be affable, available, and ready to go. And I think that can work for your first few years as you sort of figure out what is your niche going to be, what is your impact, and what are you passionate about? I think where we as women suffer is we are used to doing everything, right? And doing everything pretty damn well. And so we think that we can be a surgeon, we can be a mom, we can be a dean, we can be president of X, Y, and Z society and do all of those pieces really well. But what I say is, when I'm fully invested into one aspect, so I'll give you the example of AOS, I'm probably not going to be there at home, right? I'm traveling, I'm going to be somewhere else. Something else in my life is going to suffer. So I think you really have to enable and be ready for help. I implore a lot of help. My husband's also a physician in an academic practice. So, it's hard balancing that and having a 3-year-old, right? And so when I think about now going into my 6th year of practice, I have 2 roles, and it's the 2 Ps. And it's an easy answer for me on how to say no to things. Does it pay me or does it promote me? If it does not do either one of those things, I'm not doing it, because that is taking away time from my home, my husband, my mother, my father, all these other aspects that I enjoy being a part of and other passions that I have in life. And so you will get to that point once you figure out what your niche is. But because sometimes I am a woman and that I am Black, you're going to be invited to things because they need a woman and they are Black. But if I'm not passionate about that item, right? Digital orthopedics, for example, that is not my thing, right? So I don't need to be on that panel because 1, it's not my academic passion, even though I want to be there and I want to be participatory in it. What I always say is, no, I can't do this opportunity, but I would consider this person, right? So I try to pay it forward in that aspect. So I guess I would add that as a 3rd P, right? And so to me, that's the only way you're sensibly going to make an academic career for yourself without burning out.
Thank you. That's amazing. 3 Ps and pay it forward. That's also good. So we can always recommend each other and other colleagues to do other things. That also empowers ourselves. So Lebo, you're about to finish residency. First of all the best in your final year. So how have you been able to balance everything?
So you actually took the words right out of my mouth when you said you can actually outsource other females. And what Dr. Suleiman is saying about not having to be everywhere and deciding what you feel passionate about, I think it's a huge thing. I think also that the more you feed into this other aspect of your life, meaning the personal life, the more you can do better in your orthopedic career. I found it like that, because the support is in orthopedics as a female or anyone in a minority group, even a male. There's certain pressures that they face that we might not know of as well. And so that support that comes from home is quite important. But I think, like my co-speakers are saying, that you have to know where you're going to say no. You have to know, is it going to do anything for me or for my family? Then don't do it, you know. For me, I've got a lot of support. Like they say, I've got 3 kids, also married. But again, I say, you know, my kids are not mine. My mother takes care of them with the help of my other family members. And that's what you need in orthopedics. But for them to carry on doing that, I also need to take care of them. That means I need to take time for them. And then, you know, if this other aspect of your life is well taken care of, then one should flourish in orthopedics or any other career that one has, really, not just orthopedics. So I think in this initiative of diversifying orthopedics, we should also encourage people in orthopedics to keep a balanced work life. And yeah, thank you.
Thank you so much. And Alpha, maybe you can let us know what your experience has been with balancing everything.
Okay, all right. Listening to you guys, to Dr. Linda, I can relate so much. As a new attending and a new academic, taking an academic role now, I do say yes to everything at this point. And as a newlywed, like, it's not, I'm really learning I'm still struggling actually to balance, because this has been quite educational for me as well, because it feels like I should say yes. If I can do it, I should do it right now, but I'm still learning to say no. But right before she said delegating, paying it forward, I wrote down sponsoring. So when I think a resident of mine can do it, I give it, I let them do it. I recommend them, empower them, and make them feel like they can do it. And then they usually come through. I'm still learning how to do that, but I don't know if I'm the right person to comment on work-life integration, because I'm still learning to say no, because I'm so new to it now. I'm so new to the role. So I'm still struggling with that. I've learned a lot listening to the panelists, but I guess it's a work in progress. We all just kind of learn. The more things we take up, the more we're gonna have to learn to balance those roles, I guess. So yeah, back to you.
Yes, thank you so much. Yes, it's a work in progress. We keep trying to do better every day. As long as you're better than you were yesterday, I think that's the way to go. So I do not have any other questions from the chat box right now, and we're just an hour and 8 minutes over. I'd like to say thank you so much to all the speakers, all the panelists that we had today. We've had such an amazing conversation. We've had, I think at the height of it, I saw over 53 participants join in, and this session will be recorded and put on YouTube. So thank you to all the participants who also put some questions in the chat box, and I was trying to answer some of those. And I'm very sure that we're going to continue collaborating. I'm going to take everyone's details. We're going to keep sharing the different opportunities that are available. IODA as a platform has a lot of space, especially from industry. We are always being approached from industry to support and different initiatives and diversity, and we're going to definitely take advantage of that and keep doing it. And let's encourage our members, our friends, our colleagues to join in and participate. A lot of the time, just clicking the link and just making that application, you might find that you're the only one who applied. And I always tell people, just apply. Send the application, send your CV. It's that simple. And now I'm kind of on the back end receiving applications, and you send it out and you're like, 3 people only, and this is an amazing opportunity. Honestly, I think we need to remove that gap, and that it's not for you, it's for other people. It is for you, it is yours, it is ours, it's for us, and the time is now. So let's encourage each other to keep participating and being part of it. Thank you, Lisa from IODA, for keeping us in check, and I'd like to thank everyone. So I know for some people it's good morning, for some it's good afternoon, for others it's good evening, and others it's good night. From wherever you are in the world, thank you so much for being here. God bless you, and have a lovely rest of your weekend. Bye-bye.
Thank you.
Thank you.